Hi, my name is Dennis Freire and I'm going to talk about Langerhans cells histiocytosis complication. First definition. Langerhans cell histiocytosis is a rare disease characterized by the clonal proliferation of pathogenic Langerhans cells and cytokine overproduction. This leads to inflammation and tissue destruction in different organs of the body.
Even though this lymph node looks very pretty from a purely aesthetic point of view, I am going to spare you the agony of remembering that this might be called Langerhans cell histiocytosis, aka Hand-Schüller-Christian disease. You can always look that up some other time. However, what is abundantly apparent is that the capsule of the lymph node here is thickened, and inside the lymph node, once again, you have effacement or destruction of normal lymph node architecture, in which you have follicles with germinal centers underneath the capsule and medullary cords and sinuses inside. True, there are some follicles with germinal centers underneath the capsule and medullary cords and sinuses inside. True, there are some follicles left with germinal centers, but the overall architecture is effaced. And still, you could see that the malignant infiltrates inside this lymph node. They are not glands, they are not squamous cells, but they are still basically lymphocyte type cells. The darker ones here would be more lymphocytic. The lighter areas here would be more what we would call histiocytes or macrophages. They are all lymphoid types of cells, or the cells that you normally see in a lymph node. So, to make a long story short, you can see we have all the kinds of cells in the lymph nodes that normally populate a lymph node, but they are growing in such a way that the normal gross microscopic architecture is completely effaced or destroyed. By definition, again, you diagnose yourself another malignant lymphoma.
Applications in medicine. It may affect either a single organ system or multiple organs and commonly involves the bone, skin, lungs, liver, spleen, bone marrow, pituitary gland, and eyes. Less common sites involved include the lymph node, thyroid, ears, central nervous system, gastrointestinal system, and oral mucosa. Because pathologic Langerhans cells, dendritic cells found in the skin, are the cell type common to the various manifestations of the disease, the term LCH is preferred over previous names such as histiocytosis X. It is the most common type of histiocytosis.
Histiocytosis, LCH. The histiocytic diseases in children and adults are caused by an abnormal accumulation of cells of the mononuclear phagocytic system. Only Langerhans cell histiocytosis, LCH, a myeloid-derived dendritic cell disorder, is discussed in detail in this summary. The histiocytic diseases have been reclassified into 5 categories, and LCH is in the L group. 1. LCH results from the clonal proliferation of immunophenotypically and functionally immature, morphologically rounded LCH cells along with eosinophils, macrophages, lymphocytes, and, occasionally, multinucleated giant cells. 2,3. The term LCH cells is used because there are clear morphologic, phenotypic, and gene expression differences between Langerhans cells of the epidermis, LCs, and those in LCH lesions, LCH cells, despite the pathologic histiocyte having the identical immunophenotypic characteristics of normal epidermal LCs, including the presence of Burback granules identified by electron microscopy. LCH cells, known for many years to be caused by a clonal proliferation, have now been shown to likely derive from a myeloid precursor whose proliferation is uniformly associated with activation of the MOP/ERK signaling pathway. 4,5, however, the somatic mutation leading to the activation varies and is unknown in 10% to 20% of cases. 6. in the original breakthrough description of the BRAF V600D mutation occurring in approximately 60% of LCH biopsy specimens. The authors also described activation of the RAS-RAF-MEK-ERK pathway in almost all cases, regardless of stage and organ involvement. 7,8. Since then, activating mutations in several other genes in the pathway have been identified in a significant percentage of BRAF V600D negative LCH specimens, including MAP2K1, in frame deletions plus another leading to upregulation of BRAF, and, less frequently, the CSF1 receptor, RAS, and ARF. 9/11. In accordance with these findings, the pathologic histiocyte or LCH cell has a gene expression profile closely resembling that of a myeloid dendritic cell. Studies have also demonstrated that the BRAF V600D mutation can be identified in mononuclear cells in peripheral blood and cell-free DNA, usually in patients with disseminated disease. 3,12,13. This shows that multisystem LCH arises from a somatic mutation within a marrow or circulating precursor cell, while localized disease arises from the mutation occurring in a precursor cell at the local site. 3. The above findings have led all clinicians to agree that LCH is a myeloid neoplasm. However, discussion remains about whether it is a malignant neoplasm with varying clinical behavior. The same BRAF V600D mutation has been found in other cancers, including malignant melanoma. However, V600D mutated BRAF is also present in benign nevi, possibly indicating the need for additional mutations to render the cell malignant. 7. Nevertheless, these findings have raised the possibility of targeted therapy with inhibitors already used in the treatment of melanoma. Several trials of BRAF inhibitors are open for adults and children with BRAF V600D mutated tumors, including LCH. Refer to the
Pros and cons. Pros. Steroid therapy, such as prednisone, is used to treat LCH lesions, and these drugs are accessible. Cons. Langerhans cell histiocytosis may involve the central nervous system, with mast lesion, brain tumors, pituitary lesion resulting in diabetes insipidus or neurodegenerative syndrome. Patients with liver, bone marrow, and/or spleen involvement are the highest risk for mortality.
It's Medicosis Perfectionalis. We are back to resume our discussion about pulmonary medicine or pulmonology. In previous videos, we have talked about bazillion restrictive lung diseases. Actually, they are more than 100 diseases. Today, it's the last lecture of restrictive lung diseases. We'll talk about rheumatoid arthritis and lupus. We'll talk about Langerhans cell histiocytosis, also known as histiocytosis X, and lymphangioliomyomatosis. Who named these things anyway? Langerhans cell histiocytosis is more commoner in men. Lymphangioliomyomatosis is more common in women. With that being said, now let's get started. Lung diseases are divided into obstructive and restrictive. We are here. Restrictive is divided into extrinsic and intrinsic. Intrinsic is divided into parenchymal and non-parenchymal. Parenchymal is divided into occupational, idiopathic, and others. Today we'll talk about those others. Sarcoidosis has been discussed in the previous video. Today we'll talk about rheumatological, Langerhans cell histiocytosis, lymphangioliomyomatosis, vasculitides, and even the eosinophilic interstitial lung diseases, such as eosinophilic pneumonia, which has acute and chronic subtypes. 30% of patients with rheumatoid arthritis have a restrictive lung disease, which is an interstitial pulmonary fibrosis. The most common pulmonary abnormality in rheumatoid is actually pleuritis or pleurisy, which is a freaking sinusitis with the famous biphasic friction rub. Inhalation, exhalation. This is the biphasic friction rub. The most common cardiac abnormality in rheumatoid is the freaking sinusitis, now called pericarditis, and this one is having triphasic friction rub. Systolic, early diastolic, late diastolic. Lub-dub, lub-dub, lub-dub. Triphasic friction rub. Let's say that you're hearing a friction rub, you're not sure if it's biphasic or triphasic, you're not sure if it's pleuritis or pericarditis. Ask the patient to breathe in and hold his or her breath. If the friction rub disappeared, it was pleuritis, because the heart is still pumping, by the way. If it did not disappear, this is pericarditis. The pleurisy can
Issue applied in Ecuador. Not many cases have been present in Ecuador of this rare disease to analyze genomic alterations in LCH.
Langerhans cell histiocytosis, formerly known as histiocytosis X. I don't know when they changed the name from histiocytosis X. Now, I was in medical school probably about 10 years ago or so now, and I learned it as histiocytosis X, but when I was doing my research putting this together, now we try to avoid that name, and now we just call it Langerhans cell histiocytosis. So either my instructors were teaching it to us wrong, giving us an outdated name, or really the naming convention has changed fairly recently. This is going to be really brief. I gear my lectures towards the USMLE, and unless you're taking oncology boards as a specialty, which my lectures are certainly not enough for that, you're not going to need to know a whole lot about Langerhans cell histiocytosis. It's fairly rare. Only about 300 or 400 cases are diagnosed in the U.S. per year. You may need to know a little bit more if you are going into pediatrics, because this is primarily a disease of children. About 75% of cases occur in children. But for board-related purposes, there's only a few things you need to know about this. Really just how to identify it, not so much how to treat it. If you haven't had the opportunity yet, please consider subscribing to my Patreon at www.patreon.com/pwbmd. You can get there by clicking the link below in the description of the video, or on the I button on the upper right-hand corner of the video, and it should link you up. If you consider chipping in $1 a month, a little bit goes a real long way to help keep these videos free. And if you subscribe, you'll have access to some of my premium videos in which I go over case studies, forming differential diagnosis, treatment plan, things that will come in handy for you, both for step 3, the clinical case scenarios on the USMLE, as well as for clinical practice and putting together a real good formulaic way of going about patients and really impress your attendings. So thank you very much in advance for your consideration, and let's dive into Langerhans cell histiocytosis. So the Langerhans cell histiocytosis is often malignant, but it's a proliferation of Langerhans cells. Now, most of the versions of Langerhans cell histiocytosis, and yes, I did say versions, are not deadly. There is one that is life-threatening, but for the most part, these are fairly benign, but they can be very disfiguring, and they can be very problematic, and they certainly do need to be treated. But it is a malignant proliferation in most cases, and they are of the Langerhans cells. So remember, the Langerhans cells are those little dendritic cells.
Conclusion. Langerhans cell histiocytosis is a disease caused by somatic driver mutation at critical stages of myeloid differentiation that result in transformation of cells. An important implication of the new understanding of LCH biology is the redefinition of LCH as an inflammatory myeloid neoplasia.
I'd like to tell you about Langerhans cell histiocytosis. This is kind of a basic lecture about the disease and what we believe causes it, and a little bit about what we're going to do to treat the disease in children and adults. So we're going to call this course Histio 101. You might think of it as the overview, because there are a lot of topics that we can't go into today, but that's a chance for us to talk with you later and try to get some more knowledge out there. So this is a disease that we're going to just call LCH, because all of these words, Langerhans cell histiocytosis, get a little bit long-winded, and we'll try to make it easy for everybody to understand. As you know, it's a rare disease. It occurs in between 4 and 8 children per million population, and those numbers are gathered by studies that were done in Denmark and Sweden, where they have a very good healthcare system where they can track specific diseases. It's pretty hard for us to do here in the United States because our system isn't quite so well organized for tracking rare diseases such as LCH. But I think it's a good estimate, and based upon the number of patients that we see in our clinic and others in the United States. If we look at those numbers and think about the population of children between the ages of newborn to 18, that would mean about 300 new cases per year in the United States, which isn't very many. But there are also adults, and we have no clue how many adults are new patients each year. We guess they might be maybe 1/3 or 1/4 the number of children, but that's only a guess because no one has done any epidemiologic studies on them. We know that there are many ways of this disease presenting. It can start in the skin, in bone, in lymph nodes, liver, spleen, and lung, and we're going to talk about what it means to have the disease in those various places. Generally, there's a very good prognosis when the disease is just in the skin and the bones or lymph nodes. It's more serious when it's in the liver, spleen, and bone marrow and lung because those organs are seemingly more difficult to treat. It takes more intensive treatment, and oftentimes the people who have disease like this are very young infants who are extremely sick, and so we have essentially two populations of patients, and we call them low risk for the first group and higher risk for the second group, and we'll get into that a little bit more in just a few minutes. But overall, we cure essentially 100% of the so-called low risk group and probably 75 to 80% of the high risk group if they respond to therapy early. But I will show you some treatment results that those who don't respond within the first 6 to 12 weeks do very poorly, and that's one of our big challenges.